Good day, this is Professor Will, CVMD PhD. Today is Wednesday, April 1st, 2020. It is 4:01:59 seconds AM Eastern Standard Time, and this is my continuation on Corona series, so let's get started here. Caring for seniors during COVID-19 pandemic. Date March 31st, 2020. Source, Regent Street Institute. Summary. Scientists lay out guidelines and best practices for healthcare providers and family caregivers who are providing care for older adults during the COVID-19 pandemic. Older adults are at elevated risk for complications from COVID-19 and are dying at a higher rate than younger patients. Our senior patients need additional measures of care and protection, and COVID-19 only exacerbates those needs. Family care providers need to be aware of the hazards COVID-19 presents to their loved ones and understand how to mitigate them. I hope this information will provide helpful guidance to protect older adults during this crisis. Researchers and colleagues highlight the need to prioritize testing for older adults, even after increased screening capacity is available due to their increased risk of complications from the disease. They advise health systems to make testing available in settings other than the emergency department whenever possible and to use options such as telecare in the screening process. Caring for older adults. Older adults may be experiencing significant isolation already. Social distancing may worsen complications from seclusion. Reduced time with caregivers may also place older adults at risk due to missed opportunities to catch cognitive or general health decline and unrecognized faults. Protective equipment is necessary for caregivers to wear around patients with cognitive decline. This change in appearance may be very disorienting for patients, and patients with dementia who are required to wear protective equipment may not understand why they are doing so. Researchers and colleagues recommend that clinicians provide additional resources to caregivers and steer them toward communities to support. While fever and respiratory symptoms have been widely recognized as key symptoms associated with COVID-19, these symptoms often present differently in older adults. Fever, for example, may be blunted or absent entirely during infection for older adults. Respiratory symptoms may either be masked or exacerbated by co-occurring diseases such as COPD that can further worsen outcomes. A single oral temperature over 100 degrees Fahrenheit, or 2 oral repeated temperatures over 99 degrees Fahrenheit, or an increase in temperature of 2 degrees Fahrenheit over the baseline temperature. Experimental AI tool predicts which COVID-19 patients develop respiratory disease. Date March 30th, 2020. Source NYU, Langone Health NYU School of Medicine. Summary. An artificial intelligence tool accurately predicted which patients newly infected with the COVID-19 virus would go on to develop severe respiratory disease, a new study found. Named SARS-CoV-2, the new virus caused a disease called coronavirus disease 2019, or COVID-19. As of March 30th, the virus had infected 735,560 patients worldwide. According to the World Health Organization, the illness has caused more than 34,830 deaths to date, more often among patients with underlying health conditions. The New York State Department of Health has reported more than 33,700 cases to date in New York City. While work remains to further validate our model, it holds promise to another tool to predict the patients most vulnerable to the virus, but only in support of physicians' hard-won clinical experience in treating viral infection. The researchers' goal was to design and deploy a decision support tool using AI capabilities, mostly predictive analytics, to flag future clinical coronavirus severity. We hope that the tool, when fully developed, will be useful to physicians as they assess which moderately ill patients really need beds, and who can safely go home with hospital resources stretched thin. For the study, demographic laboratory and radiological findings were collected from 53 patients as each tested positive in January 2020 for the SARS-CoV-2 virus at the 2 Chinese hospitals. Symptoms were typically mild to begin with, including cough, fever, and stomach upset. In a minority of patients, however, severe symptoms developed with a week, including pneumonia. The goal of the new study was to determine whether AI techniques could help to accurately predict which patients with the virus would go on to develop acute respiratory distress syndrome, or ARDS, the fluid buildup in the lungs that can be fatal in the elderly. For the new study, the researchers designed computer models that make decisions based on the data fed into them, with programs getting smarter the more data they considered. Specifically, the current study used decision trees that track series of decisions between options, and that model the potential consequences of choices at each step in the pathway. The researchers were surprised to find that characteristics considered to be hallmarks of COVID-19, like certain patterns seen in lung images, e.g. ground glass opacities, fever, and strong immune responses, were not useful in predicting which of many patients with initial mild symptoms would go on to develop severe lung disease. Neither were age and gender helpful in predicting serious disease, although past studies had found men over 60 to be at higher risk. Instead, the new AI tool found that changes in three features: levels of the liver enzyme alanine aminotransferase ALT reported myalgia and hemoglobin levels were mostly accurately predictive of subsequent severe disease. Together with other factors, the team reported being able to predict risk of ARDS with up to 80% accuracy. ALT levels, which rise dramatically as diseases like hepatitis damage the liver, were only a bit higher in patients with COVID-19, researchers say. It still featured prominently in prediction of severity. In addition, deep muscle aches, myalgia, were also more commonplace and have been linked by past research to higher general inflammation in the body. Lastly, higher levels of hemoglobin, the iron-containing protein that enables blood cells to carry oxygen to bodily tissues, were also linked to later respiratory distress. Could this be explained by other factors, like unreported smoking and tobacco, which has long been linked to increased hemoglobin levels? Of the 33 patients interviewed on smoking status, the 2 who reported having smoked also reported that they had quit. Limitations of the study say the authors included the relatively small data set and the limited clinical severity of disease in the population studied. The latter may be due in part to an as yet unexpected dearth of elderly patients admitted into the hospitals during the study period. The average patient age was 43. Researchers will be paying more attention in clinical practice to their data points, watching patients closer if they, for instance, complain of severe myalgia. It is exciting to be able to share data with the field in real time when it can be useful. In all past epidemics, journal papers only published well after infections had wings. Good day, this is Professor Will, CBMD PhD, on infectious disease and microbiology. I hope you enjoyed listening and have a great day.